all set. Yeah.
All right. Hello, everyone, and welcome to our grand rounds. I hope everyone had a great Labor Day weekend. As you can see, please return next week for our annual Leon Kochman lecture in rheumatology given by Dr. Anne Marie Malfait, titled Biologic Basis of Pain in Osteoarthritis. So today's Grand Rounds is a special UMB Institute for Clinical and Translational Research lecture, and we are privileged to have Dr. Deidre Cruz give the lecture today. Dr. Cruz is a professor of medicine in the Division of Nephrology at Johns Hopkins University School of Medicine and the Deputy Director for Inclusive Research for the Institute for Clinical and Translational Research. She holds appointments with the Schools of Public Health and Nursing, the Welch Center for Prevention, Epidemiology and Clinical Research, the Center on Aging and Health, and the Center for Health Equity, where she is a Deputy Director. An elected member of the American Society for Clinical Investigation, the Association of American Physicians, and the National Academy of Medicine, Dr. Cruz's work has elucidated root causes of the disproportionate burden of kidney disease among socially marginalized populations and addressed social and behavioral risk factors for adverse kidney outcomes through interventions. She currently serves as president of the American Society of Nephrology. And Dr. Cruz, I turn it over to you.
Well, thank you so much, Dr. Kwan. I really appreciate the kind introduction. I'm really delighted to be with you all today. I asked Dr. Kwan, I said, "Oh, do you all usually have virtual grand rounds?" As I certainly could have made the short drive across town if if you all were doing in-person rounds, but I'm happy to join you virtually. I'm going to attempt to share my screen here and get us started. Let's see here. See. Okay, hopefully that is projecting
Perfect.
just fine. Okay, thank you. So great. So what I'll be sharing with you all today is a bit on the subject of addressing social needs to achieve kidney health equity. And I'll be focusing on kidney health equity. As you heard, I'm a nephrologist, but hopefully a lot of what I'll be discussing today will also apply to a number of other, particularly a number of other chronic diseases. So these are my disclosures. I won't, though, be discussing any commercial products of these or really any other companies during our time this afternoon. So our objectives are first to recognize some of the profound inequities that exist in kidney health, and including some of the societal impacts as well as the potential root causes of these inequities. We'll go on to focus particularly on social drivers of kidney health inequities through this lens of social needs. And then finally, I'll try to share with you all some prior and ongoing work that's been conducted to identify and also try to address these inequities. So first, understanding that this is a joint ICTR and medical grand rounds session, I thought we could start with a case. So this is a case of Mr. H, a patient of mine who is a 48-year-old Black man who has a history of end-stage kidney disease that's been attributed to hypertension. He has been treated with hemodialysis for the past 14 years. And at the time of when he was initiated on dialysis, he had an urgent inpatient initiation. He earned his GED some years ago, and he has had intermittent periods of unemployment. Where I've been able to notice some things even clinically about what's going on with him during these times of unemployment. He lives with friends or does what's often referred to as couch surfing, sort of bouncing between different friends' homes. His serum phosphorus is often not at goal. Many of you may know that serum phosphorus is something we follow very closely in the nephrology space because of its association with, particularly with greater risk of cardiovascular events, and his level is often not at goal. He is interested in transplantation, but he's currently inactive on the wait list, in large part because he has not been able to complete all of the visits required to sort of get become active on the transplant wait list. But despite that, he is extremely conscientious about his health, his medications, and his appointments, and he's quite adherent with each of these things. Now, as mentioned, we'll cover a bit about what we know about inequities in kidney health. And what we know is that these inequities are quite profound. Black, Hispanic, and Native American people have higher rates of kidney failure than do non-Hispanic white people. We know that these racial and ethnic disparities are not fully explained by genetic risk variants, including many of you may be familiar with what we know about the apolipoprotein L1 genetic risk variants, which are prevalent between for between 12 and 15% of Americans who have African ancestry. So here predominantly people who would self-identify as being Black individuals or of Black race. And we know that even when we look at studies that have been conducted where they looked at those individuals who have African ancestry and have the lower risk variants of apolipoprotein L1 and compared them to people who predominantly have European ancestry, we continue to see disparities. So meaning that even among, even when we compare those who don't have these high risk genetic variants to people with European ancestry or predominantly white individuals, we continue to see racial disparities, really underscoring that these types of disparities are not fully explained by genetic risk variants. We also know that people who have lower incomes have higher rates of chronic kidney disease. And a real challenge in our field is that it's been estimated that 9 out of 10 people who have chronic kidney disease are actually not aware of their disease. And what we find is that awareness tends to be lowest among some of the groups that are actually at the highest risk of going on and developing some of the complications of earlier kidney disease, including progression to kidney failure. Now, I should note, I will take questions at the end. So I see there's a hand raised, but I will circle to questions at the end, if that's okay. So I'm sure that in this Zoom room, if you will, we can all agree that health inequities are inhumane. As it turns out, they are also extremely costly, both in terms of the cost to humans, to human life, as well as fiscally or financially costly. It's been noted that over about a 22-year period that Black people in the U.S. experienced around 1.6 million excess deaths and more than 80 million excess years of life loss as compared with white people. This has been thought to be driven by health disparities. It's also been estimated that $1.2 trillion are spent due to the combined cost of health inequities and the subsequent deaths that occur among minoritized groups. And this again is due to their inadequate and or inequitable care. And a real challenge is that the U.S. actually spends less on social services than our sort of peer countries around the world, those that would be considered our kind of economic peers around the world. And in fact, we are the only country that spends more on healthcare services than we do on social services as a percentage of our gross domestic product. And it's that last point that many argue is the reason that we, despite having our economic status in the world, we as a nation don't realize the health benefits of that economic status. That it's really what underlies that is the fact that we don't invest as much in social services. Now, this is an understudied area in the kidney disease space, but what we know is that the cost incurred by Medicare when it comes to the care of people with chronic kidney disease, it does tend to rise as those individuals have more severe chronic kidney disease. So meaning that those who have earlier stages, such as stages 1 to 2, tend to have less, there tend to be less Medicare-related costs for those individuals as compared to those who have more advanced stage chronic kidney disease, such as stages 4 and 5. Now, when we look in particular at those who have more advanced chronic kidney disease, what we see is there are racial differences in the amount of costs that tend to be incurred for those individuals, including with for Black or African Americans and people of other race having a greater cost than do white individuals, related again to the care of their kidney disease. Now, a number of different sort of conceptual models have been put forward to help us think through what might be the root causes of why a number of different socially marginalized populations have greater risk of kidney disease. Um, and as well as the consequences of kidney disease. I will point you first to those factors that are on the right-hand side of this particular model. This is a model that I like largely because I think it really does capture the three major drivers here of this issue. So on the far right-hand side are those issues that can stem from either from a person either being uninsured or underinsured. So of course they're referring to factors such as limited access to healthcare or limited healthcare utilization when it would otherwise be appropriate utilization. And then, of course, that can then set people up to have reduced detection of them having chronic kidney disease, as well as less risk factor sort of treatment. So thinking here, for example, of diabetes, which is the leading cause of chronic kidney disease in the US, and people certainly who have uninsurance or underinsurance tend to not have their diabetes well managed, and that can raise their chances of developing kidney disease. And then, of course, from there, those individuals can go on and develop progression of their kidney disease and ultimately either have premature mortality or develop kidney failure or end-stage renal or end-stage kidney disease. In the middle of this figure are those factors that can stem from the experience of discrimination. So here thinking about not only the psychosocial factors that can stem from this, so things like having depressive symptoms or chronic stress, but also the kind of the way that the experience of discrimination has been documented to also influence the way that people go about managing their own health or adopting or avoiding, in some cases, what might be health promoting behaviors. So things like we know that through the literature that people who have experience of discrimination are more likely to take on substance abuse, physical inactivity, and overeating than people who have not had this experience of discrimination. That can then lead to real biologic consequences, of course, setting them up to have some of the more clinical risk factors for kidney disease that we think of, such as obesity, diabetes, hypertension, cardiovascular disease, and others. Now, on the far left-hand side of the same figure are those issues that can stem from residential segregation. So here, particularly thinking about racial residential segregation, but where what we can see is people who live in homes, live in communities where there has been limited investment in the educational systems, there's overcrowding, there's poor housing infrastructure, exposure to environmental toxins like lead and others that we know can raise their risk of developing kidney disease, as well as in large part because of the lack of investment in the educational systems in many of these communities, there may be low health literacy and low educational attainment, as well as many of these same communities have less access to healthy foods as well, which can then lead to poor nutrition. Now, in our time together today, I'm going to highlight these two factors just to illustrate both some of what we've been finding as it relates to kidney disease, as well as to think about some of the types of interventions that might be undertaken to address these challenges. Now, I mentioned that model. I think important to note, though, that increasingly what sort of sits atop the model that I just shared with you, it's being recognized that really it is structural inequities, including structural racism, that really sits atop that whole model. And here, thinking about when we think of structural racism, it embodies the many ways in which a society fosters racial discrimination through inequitable allocation of resources and opportunities that are embedded in these mutually reinforcing systems. So systems like housing and access to healthcare and access to nutritious foods. What these are often referred to as the social determinants of health, of course, and increasingly these are being recognized as the major cause of race-based health inequities. And groups including the NIH are increasingly starting to recognize this I was honored to co-chair a workshop that the National Institute for Diabetes, Digestive, and Kidney Diseases hosted a couple of years ago, focused on identifying ways that interventions could be designed to address the impacts of structural racism on kidney health. And out of that workshop, then a request for applications was put forward for groups to actually apply to conduct clinical trials to address these issues, and those clinical trials are now ongoing. But the NIDDK is one of several institutes within the NIH that has been addressing this issue. Now, turning first to some topics really that underlie this issue of residential segregation. So we know that residential segregation is among the most potent forms of structural racism, and highly discriminatory policies such as that of redlining, which I'm sure many of you are familiar with, really does have really been the root causes of what we see really today, even around residential segregation. So just as a reminder, redlining was a discriminatory practice by which banks, insurance companies, and really other groups who were in a position to lend money to either individuals or to businesses would restrict their lending to geographic areas where or limit their lending to geographic areas where the residents were predominantly Black individuals, as well as this practice was sort of levied against religious minority groups, including Jewish individuals. Now, many of you may know that our city, Baltimore, was considered a leader, and I should say in air quotes, in this highly discriminatory process of redlining, in that in the 1930s, Baltimore was among the first cities to adopt this practice, where these types of maps, like the one I'm sharing on the screen, were drawn for the city, and those communities that were shaded in red were considered hazardous places for lenders to provide financing for people who were either purchasing homes or businesses, whereas those who were shaded in green were considered the best or most optimal communities for this sort of lending, and those shaded in blue were considered kind of still desirable, but certainly not considered as desirable as those shaded in green. Now, if we then look here in Baltimore, if we look at more present day data, what we find is that even 5 miles makes a world of difference when it comes to health in Baltimore. If we look at, for example, the Roland Park and Poplar Hill communities, what we see is that around 83% of the residents are white people. The median household income is around $104,000. The unemployment rate is very low at about 2.3%. The homicide rate is essentially non-existent. The life expectancy is around 84 years, which really does rival some countries around the world, such as Japan, that enjoy very long life expectancies, particularly relative to the U.S. general average life expectancy. And the death rate from heart disease in Roland Park and Poplar Hill is also considered fairly low. Whereas if we look at the Madison or East End communities, what we see is that 90% of the residents are Black or African American. The median household income is about a quarter of that in Roland Park and Poplar Hill. The unemployment rate is more than 10 times that community. The homicide rate is high, and the life expectancy is 15 years less than what it is in Roland Park and Poplar Hill, and the death rate from heart disease is more than 3 times in that of Roland Park and Poplar Hill. And you might recall from the previous slide that this is the same community that had been redlined now about 100 years ago. Now, we were interested in understanding whether we are potentially seeing effects of historical redlining on the rates of kidney failure that we now see in recent years here in the U.S. And so this was work with Dr. Kevin Wynn, who's based at Boston University. And what we did here was to look at adults that were living in 141 different metropolitan areas in the US and had sort of been living there in this sort of about a decade ago. And what we were interested in is examining whether these individuals were living in communities that had been redlined. So those communities that had been given a grade D or had been considered hazardous places for banks and others to sort of lend to. And then we were wondering whether living in such communities today then meant that those same communities had higher rates of kidney failure. And so what we found was indeed that residents in what had been a historically redlined census tract was associated with significantly higher rates of kidney failure today compared to residents in those communities that had been given that grade A or best rating, that green area that was in the map a couple of slides ago. We also importantly found that this was true for individuals of all racial and ethnic groups. So meaning that regardless of the individual race or ethnic group of the people that were living in these communities, their dwelling in that community meant that the rates of kidney failure were higher for them. But I think importantly, when we then look specifically at Black individuals, again, where a group that we know have in the US higher rates of kidney failure than do white people, what we found is that for Black people living in these census tracts that had a grade D rating, they had a higher rate of kidney failure than those Black individuals living in the grade A or sort of best communities. Again, using present day data. Again, underlying that it's not this sort of to the extent that we know that most people who self-identify as being Black have African ancestry. It's not an ancestry thing. It's not a genetic thing that is really underlying this. This is clearly an environmental factor or environmental factors that really are underlying this disparity. Now, of course, one of the important things that are important factors or things that are really important for, or social need that's really important for people is that issue of housing, having stable housing. And we know that discriminatory practices like redlining and present day residential segregation that is related to that can shape a person's ability to have safe and affordable housing. We were interested in this study that was based here in Baltimore at what the relationship is between the experience of housing instability and the engagement in the healthcare sort of setting for people who have chronic kidney disease. And so we use data from a Baltimore-based cohort study called the HANDLES study. It stands for the Healthy Aging in Neighborhoods of Diversity Across the Lifespan study, quite a mouthful, but HANDLES study for short. And we kind of zoomed our attention in on those 350 or so participants who had chronic kidney disease at baseline in the study. And what we found is that about more than a third of them reported experiencing housing instability based on questions such as, are you able to afford a suitable home for you and your family? Or have you had difficulties making rent or mortgage payments? And then we also noted that among the same population, that about a quarter of them had reported postponing medical care when they otherwise felt that they needed to seek medical care. And when we went on to sort of analyze this information, what we found is that even after accounting for a number of different factors, people who were experiencing housing instability were, so that experience was independently associated with postponing medical care when otherwise that medical care was felt to be needed. So in a sort of subsequent study, we were interested in then looking at how having unstable housing or housing instability may or may not relate to risk of mortality. Again, here focused on individuals who were receiving dialysis, and we focused here on U.S. veterans, so using the VA data, and we made use of the fact that and many of you may know, because I know many of you practice at the VA, Many of you know that there's really extensive screening that's done for social needs for veterans who are cared for through the VA. And we made use of that data to then categorize whether at the start of dialysis, these veterans had been documented to have unstable housing or they had stable housing. And what we found was that those who were experiencing unstable housing had a greater risk of mortality than those who didn't, and than those who had stable housing. And this was particularly true among older veterans, so those between the ages of 75 to 85 years. Now, another social need that has been really or is very shaped by practices such as redlining is this issue of healthy food availability. Um, so in this study that looked at the amount of healthy food available in Baltimore, what they did was, and these were colleagues here at Johns Hopkins, what they did was they sent out a team of research assistants to all of the food outlets in the city, and Baltimore County as well. And what they were documenting was the sort of presence or absence of healthy food, so fruits, vegetables, whole grains, low-fat dairy foods. And you'll note that in the area that's in the square here, that's Baltimore City, of course. And what they were documenting was if there was a high amount of healthy food that was available, that was indicated by the size of the green circle. And then the racial composition of the communities were noted by, for those that were in the darkest shaded gray, those were the predominantly white communities, and those that were noted in white were the predominantly Black communities. And you'll note that those communities that did have that there was a greater amount of healthy food that was noted to be available in those predominantly white communities. And they found a similar pattern when they looked across median household income levels as well. And this type of, I'm sharing with you, it's very comfortable to share this with you as a fellow Baltimoreans here, but I'm sharing this data on Baltimore, but this has been replicated in other studies across the country, this similar type of finding. So we know that these types of practices, as well as the disinvestment in these sorts of communities, has certainly shaped the food environment in these areas. Now, another related issue to healthy food availability is this issue of food insecurity. And so one definition of food insecurity is sort of the limited ability to afford nutritionally adequate foods. And we know that around 44 million people in the US experience food insecurity, and it impacts people in every county. 100% of counties across the US have individuals living in them that are experiencing food insecurity. We were interested in the relationship between food insecurity and risk of progression to kidney failure for individuals who already had chronic kidney disease. And so this is using data from the National Health and Nutrition Examination Survey, or NHANES, where we made use of the extensive amount of data that they've collected on nutrition for those participants, and then linked that data to Medicare data to look at the rates of start of dialysis. Essentially, what we found was that people with chronic kidney disease here in the US who were experiencing food insecurity were more likely to see that chronic kidney disease progress to kidney failure and a need to start dialysis as compared to people who had food security. Now, when we went on to account or adjust for different factors that we know have a relationship with either progression of chronic kidney disease or with the types of foods that people may consume, we were, I think, in many ways encouraged to find that when we accounted for nutritional factors, so things like how many the number of calories they were consuming, kind of the composition of the types of foods that they were eating from a nutrient standpoint, we were able to at least statistically explain away this this relationship between food insecurity and progression of kidney disease to kidney failure. Really, for us, suggesting that maybe, despite knowing that food insecurity sometimes can be a marker of other sources of financial strain, that perhaps if the diet of such individuals could be intervened upon, perhaps we could mitigate that risk or that chance of them progressing to develop kidney failure. And so this work was also coming at a time when we were doing some other studies, just trying to understand what types of dietary patterns are associated with favorable outcomes with respect to kidney health. And through a series of studies, some of them highlighted here, essentially what we were finding is that those dietary patterns that are rich in fruits and vegetables, whole grains, low-fat dairy foods, such as patterns like the DASH diet, the dietary approaches to stop hypertension dietary pattern, are associated with better outcomes, whether it's developing kidney disease in the first place or seeing that kidney disease progress. We were finding relatedly that those patterns that presented less acid to the kidneys for handling, so those dietary patterns that had a lower amount of dietary acid load, which tend to be patterns that are rich in fruits and vegetables, those were associated with favorable outcomes. So when we then thought, though, about populations that we might want to support in following such healthy dietary patterns, we wanted to then engage a group of African American or Black individuals to sort of really explore this. And so we focused on a group of individuals who had first-degree family members who had kidney failure. And we did focus groups with them, and we actually asked some questions about what they thought might either be a barrier to them being able to make healthy dietary changes to hopefully lower the chances of them developing kidney failure as had their family member. And I should mention as well that these same individuals also already had clinical risk factors such as diabetes, heart disease, hypertension as clinical risk factors for developing kidney disease. So some of the things that they mentioned were that healthy foods are expensive and unavailable in certain neighborhoods. One participant said, and what we have in our neighborhoods and most low-income neighborhoods is fast food restaurants everywhere. You hardly see a farmer's market or fresh produce stand or even fresh produce in the supermarket. And as soon as you walk in the market, the first thing you see is cakes, cookies, chips, cereal with loads of sugar. They also highlighted that unhealthy foods, in their view, are more convenient to prepare and to access, and that unhealthy dietary practices had been a lifelong habit. And so they felt like that would make that habit very difficult for them to break. In a sort of related study, we invited a group of Black adults living here in Baltimore who all had a history of hypertension, and many of them also had a history of also had chronic kidney disease. And we conducted a photo voice project. Now, I wonder how many of you are familiar with photo voice, perhaps some of you, but this is a participatory research approach that involves training the participants to use cameras to photograph something in their environment. And then they come together after that, usually in sort of group settings, to discuss what is being shown or sort of seen in those photos. And often then the findings from these types of studies are used are used for advocacy efforts, really around shaping something in the environment. In our case, we focused on the food environment here in Baltimore. One of the participants in our study highlighted this photo on the left and said, this vacant building, now people start sitting and drinking in front of it. This is an eyesore. People leave trash, which attracts rats. This building could be turned into an Aldi's. Discriminatory practices against Blacks don't allow them to buy lots and buildings. It's not affordable to a lot of people, so they give up. People want to do good, but don't have the money. We can have liquor stores, but not a market. And so this is what they were seeing in their environment. Now, I've highlighted a lot of, I think, barriers to healthy eating or sort of health promoting behaviors. I also want to mention that through our work, we have certainly identified a lot of assets that some of the same communities that we would be interested in supporting to reduce their chances of developing kidney disease or seeing that disease progress. We've certainly been able to identify that through them, including this one gentleman who had noted what was in his sort of environment and had developed his own garden where he was certainly providing food for himself and his family, but also his neighbors. He noted, I tried something I saw out at a store at home. It saved money and it was good. It's complicated to try shopping. People with cars can get around. People in the neighborhood have no access. I try to help when I can. Concerns about crime and safety. If it was easier to get stuff, crime would decrease. And so really considering these different challenges as well as these different assets that we'd noted through our work, we fairly recently completed a clinical trial called the 5+ Nuts and Beans for Kidneys trial, which was a 12-month, 2-phase, community-based randomized controlled trial for 150 Black adults here in Baltimore that was aimed at addressing some of the real-world obstacles to healthy eating. Now, our central hypothesis for this trial was that the delivery of nutritional advice to adopt a DASH-like diet plus the provision of $30 a week worth of potassium-rich foods would lead to a 20% greater reduction in urinary albumin excretion, so the excretion of the small protein, albumin, as well as improvements in blood pressure when compared to the provision of a grocery gift card without nutritional advice. Now, this was a community-based participatory research study or community-engaged research study where we had numerous partners and stakeholders, including our grocer partner, ShopRite. So this was our protocol for the study. It had two arms. So after randomization, the participants were randomized to one of two groups. So the group on the top here was the self-directed or S-DASH diet group, which in the first 4 months of the study, they received a gift card to ShopRite that was worth $30 a week, so about $480 worth of this gift card. And they also received a brief overview from our study coach about the DASH diet, and this was at randomization. And then in the second phase of the study, the last 8 months, they did not receive a weekly food allowance, but were told, please follow what you had learned about in the about the DASH diet. Now that was compared to the C-DASH group, the dietitian-directed coaching group, who in the first 4 months received assistance ordering $30 a week worth of these 5+ foods, as we referred to them, that were delivered to their home. And they also received these brief coaching calls with the study coach, wherein the food for the next week was the food order for the next week was placed, as well as they would give them tips about how to incorporate these healthy foods into their way of eating. And then in the second phase of the study, the same group did not receive the weekly food allowance. Rather, they, though, continued with sort of less frequent telephone visits with the study coach. So I'll share with you the results of our first 4 months of the study, which was our primary endpoint. But first, I want to tell you a little bit more about the kind of what was involved in the intervention. So we would provide each participant with a selection of about 60 different foods that were sold at ShopRite, with a big focus on trying to increase their potassium intake. So these are some example foods that are noted there on the left, and the potassium content for those foods. We also were trying to support them in taking in 5 servings a day of fruits, vegetables, nuts, and beans. So a total of 5, but across those different food types. And each week we would support them in ordering 17,000 milligrams worth of potassium to try to, again, have them get closer to the DASH dietary pattern of more than 4,000 milligrams or 4 grams a day of potassium intake. So we would provide in the groceries, as it turned out, it ended up being, if you think about those plastic bags, $30 worth of these types of foods ended up being about 6 or 7 of these bags. And so in those bags, we would also include tip sheets, including things like how to eat 5+ for folks who don't cook, because we had found through some of our focus group studies that a lot of people said they just don't cook really at all, and that they eat all their meals outside of the home, or meals that are prepared outside of the home. So these are our 4-month outcomes that I'll sort of walk you through. So what we found, first off, when we compared again the coaching DASH group to the self-directed DASH site group, we found a suggestion of a greater reduction in urinary albumin excretion, so urinary albumin to creatinine excretion for those that were in the coaching DASH group. So not statistically significant, but in the direction of there being a benefit. But when we looked at other sort of factors, we did note that I'll start maybe on this sort of left column, that when we looked within the group who had received coaching, we noted a statistically significant decrease in urinary albumin excretion when compared sort of back to baseline for that group of almost 29% less albumin excretion, as well as statistically significant a significant reduction in diastolic blood pressure and improvement in urinary potassium level, which is a marker of the actual dietary potassium intake. And then likewise, we did see here on the far right-hand column that compared to the self-directed DASH diet group, those who received the coaching had a greater increase in their urinary potassium, as well as a greater amount of self-reported potassium intake, as well as self-reported fruit and vegetable intake. When we went on to look at some important subgroups, we found some significant findings. So including when we focused on those participants who had very high albuminuria, so they were losing more than 300 milligrams of albuminuria each day, is sort of the estimate. Or in each sample, I should say. We found that those who were in the coaching group had a significantly greater reduction in their albumin excretion as compared to those in the self-directed or shopping DASH group. And we found a suggestion of a greater benefit for the coaching portion, a coaching arm of the study for individuals who had diabetes as well. Now, I'll turn a bit here in the last few minutes to some healthcare system and public policy approaches surrounding this issue of particularly of healthy food. So we know from this systematic review that was done a few years ago that a number of different U.S. healthcare entities have programs that screen patients for and address food insecurity. So the majority of these systems use the Hunger Vital Signs screener questions, which ask about the past 12 months, and they ask whether an individual had worried whether their food would run out before they got money to buy more, and they ask questions about whether the food we bought just didn't last and we didn't have money to get more. And then if there's an answer in the affirmative, that can indicate that these individuals may be experiencing food insecurity. And then for these health systems, about more than half of them would then track that food insecurity data in the patient's electronic health record. And then most would also refer such individuals to food resources. So things such as food banks, federal benefit programs such as the Supplemental Nutrition Assistance Program, medically tailored meals, which some of you may be familiar with, which are programs where the individuals receive prepared meals, usually that they just have to heat in an oven or microwave, that have taken into account all the different types of health conditions that that person may be dealing with. So we think about, for example, people who may have both advanced chronic kidney disease, and they may have maybe they have atrial fibrillation, and they're taking warfarin for their for anticoagulation, and so they need maybe a low sodium, maybe a lower potassium diet that is also low in vitamin K, so that it doesn't interfere with their anticoagulation. And so these types of medically tailored meals can take that into account. A number of these systems also have on-site food pharmacies or pantries, and these really are as they sound. So similar to how we're familiar with medication pharmacies, a typical pharmacy. At these sites, a clinician can actually sort of write a prescription for the types of foods that they think their patient should consume. And then often on the same site, they can then go and acquire those foods that again might support their health, really, and again to obtain them right there at the site of the clinic or the broader health center. Now, in this study that was focused on the SNAP benefit, the Supplemental Nutrition Assistance Program, what they looked at, and this was based in North Carolina, they looked at individuals who were over 65 years of age and were enrolled in both Medicare and Medicaid. So with Medicaid, indicating that they had a lower income level, but were not at the time of this analysis, were not enrolled in SNAP. They were not receiving that nutrition benefit. And then they followed them over time, and they found that about 5,000 of them actually did enroll in SNAP. Now, when they went on to compare these groups, those that did enroll in SNAP versus those that did not, they found that SNAP enrollment was actually associated with fewer inpatient hospitalizations, emergency department visits, long-term care admissions, and actually savings around $2,300 in savings in terms of Medicaid payments per person per year, really underscoring the sort of financial and other benefits of making sure that people who are eligible for receiving the SNAP benefit are actually receiving it. Now, one of the things that's known is certainly there are racial disparities that have been well documented in food insecurity with, for example, Black and Hispanic individuals having a greater burden of food insecurity here in the US. In this analysis with my colleague, Dr. Laura Samuel, based here at Hopkins in our School of Nursing, what we were examining was the sort of household composition in terms of sort of race and ethnicity, and the rates of SNAP usage, and then how that then related to the rates of food insecurity. What we found is that for households that did not participate in SNAP, those that were households where all of the residents self-identified as being Black or were multiracial, they were more likely to be experiencing food insecurity than those white households. But among SNAP participants, so people actually receiving that benefit, Black households were actually less likely than white households to be experiencing food insecurity. So really here again, underlying and underscoring that SNAP is actually a program that seems to work with respect to food insecurity, but there are a number of different gaps in participation in SNAP. So one of the things that we've done to try to advocate for some of the policy changes that we think would need to happen to sort of to address some of these broader issues really that impact the food environment here in Baltimore and more broadly in Maryland, is to hold, this was a couple of years ago, but to hold this this symposium where we brought together a number of different policymakers and others who have an interest in this topic, and had an exhibit of some of those photos from the Photo Voice project that I mentioned to you, really to talk about what needs to be done to promote a more inclusive food environment here in the city. So I want to return back to Mr. H, just to hopefully highlight some of the things we've talked about. So you'll recall that he, for example, had experienced these periods of unemployment and also had a serum phosphorus that was often not at goal. One of the things that I've learned from caring for him is that his phosphorus levels tend to be more poorly controlled during times when he's been experiencing unemployment. And he shared with me that his diet tends to change in those settings, that he tends to then eat more processed foods when he is when he doesn't have as much money or doesn't have a stable income to purchase, have a more broad and maybe healthier dietary pattern. Of course, in noting that he was living with friends and couch surfing, it was clear that he has been experiencing housing instability or housing insecurity. I mentioned this piece about him being interested in transplant. He's had a tremendous difficulty sort of navigating many of those appointments and things that have really kept him inactive on the list, really due to sort of these repeated bouts of having various illnesses and not being able to kind of keep up with those visits for transplant in between those. And so what we know is Mr. H is pretty similar, we found, in terms of what we see among dialysis patients, really particularly in this area. So we, through this study, this was with Dr. Catherine Taylor, also based here at Hopkins. What she did was to develop this cohort of individuals treated with dialysis here in the Baltimore and Washington D.C. Areas. She recruited 305 participants and screened them for things like food insecurity and housing instability. And one of the key things that she found were that for those individuals in this study, for those that were living in what had been or what are racially segregated areas, again, communities that may have been impacted by practices such as redlining, she found that for men in particular, that their risk of experiencing food insecurity was greater if they lived in these types of communities. She also found that the risk of food insecurity was greater for people, again, living in these types of racially segregated communities if they were younger. So the risk of again, the risk of food insecurity was higher. And many would argue maybe that's because we don't have as many supports, particularly for young adults who might be experiencing food insecurity, the way that we have a number of different programs that support older adults that they may be able to access, including things like medically tailored meals. And so through a number of different, writings, things, we've been trying to advocate for policy changes that we think might actually help to impact both what we see as far as food insecurity for people who are experiencing kidney disease, as well as housing insecurity, including an article where we called for consideration of permanent supportive housing for people with end-stage renal disease or kidney failure who are experiencing homelessness, similar to the program that exists for people living with HIV. And so really to summarize what we've covered today, we know that inequities in kidney disease are profound and they have significant societal impacts. Some of the root causes of these inequities include limited access to high quality healthcare, discrimination, and downstream impacts, and numerous downstream impacts of residential segregation, which can include unmet social needs. Achieving kidney health equity, in my view, will require a commitment to designing interventions and also advancing policies that draw upon some of the strengths that we know exist for these communities, as well as addressing the needs of historically marginalized communities. So I want to end here by acknowledging the participants of the studies that I presented, as well as my colleagues at these centers that are highlighted here, as well as my division of nephrology, as well as highlight for you all that for those that work in the kidney space, that we have a relatively new center called the Johns Hopkins O'Brien Center to Advance Kidney Health Equity, which is focused on kind of harnessing the expertise we have here in both basic and clinical research in kidney diseases to help investigators around the country to conduct the work that they're doing that might actually help us to both identify the mechanisms that sort of underlie these disparities, as well as to address them. So I will invite you to reach out if you have an interest in that, and I will otherwise end here. Thank you.
Thank you so much, Dr. Cruz, for the really interesting talk. I think we have a few minutes for a couple of questions. One I see is from an anonymous attendee. I thought plant-based protein is not good for chronic kidney failure other than meat-based protein. Is that still correct?
Okay, thank you. Thank you for the question. I'll see if I can see it on the screen here. So that is not so. So there is I think a lot of people have had concerns about plant or just plants in general. So when we promote dietary patterns that might be rich in potassium, which is the case for many plants, that there's concern about the potassium content being difficult for people with chronic kidney disease to handle. We're having more and more literature coming out showing us that that's probably only true for a very small proportion of people with chronic kidney disease, maybe those with very advanced disease, but for the vast majority of people with chronic kidney disease, the a potassium-rich diet is safe. Now, the comment about protein. So this attendee may be familiar with the work around the modification of diet in renal disease study, which did test different levels of dietary protein intake, and essentially found that it didn't lead to as much of a slowing of progression in chronic kidney disease as had been demonstrated in some smaller studies. And so there are still many clinicians that try to limit the animal-based protein that their chronic kidney disease patients consume, but less so in terms of limiting the plant-based protein, where we know, people do need protein, and we know as well that particularly people with advanced chronic kidney disease may be at risk for frailty, and so we want to make sure that we're not or at risk for malnutrition and frailty as a potential consequence of that, and so we try not to limit that for those people. Other questions? It's a quiet group. Okay, I see one. Oh, so thanks. So a question about a correlation between the amount of dialysis centers that are built in redlining communities. I'm not sure. Maybe the attendee could clarify the question a little bit more, but if I understand what you're asking, is it are you wondering if the number of dialysis centers in a community correlate with whether or not that community had been redlined? I would say I would expect that they might, for the reasons of kind of a supply and demand reason, harkening back to the data that I shared with you, where we were finding that the rates of kidney failure were higher in those communities, and so one would expect that, particularly we have 2 large dialysis organizations in the U.S. who have more than 70% of the market share of dialysis facilities. So you would imagine that they are tracking like where the highest rates of kidney failure tend to be, and then setting up their dialysis units in those communities. But I hope I answered your question. If not, please clarify it in the chat or elsewhere. So I see another. Thank you. Educational difference between the communities. Yep. Thank you. So maybe the first piece about educational difference between the communities. So as I mentioned, when I was sort of talking about that model of what we see, particularly some of the downstream impacts of residential segregation, we know that that tends to be less investment in the educational infrastructure, educational offerings in some of these same communities, and so certainly to the extent that has affected many of the people that maybe today that we may see and treat as dialysis patients, I would expect there to be some differences in terms of educational attainment and sort of the quality of the education that they may have attained. So certainly that is likely a factor. The other piece you mentioned was about transportation. So yes, most dialysis facilities have, really all U.S. dialysis facilities have access to social workers who often have a greater caseload than what is manageable for many of them. But one of the things that is within their sort of scope of practice is to support patients with identifying different services for stable transportation. But transportation is absolutely a major challenge in terms of supporting patients being able to adhere to their dialysis treatment schedule. Other question? Let me see. I'm going to go over to the chat. Okay, great. So it's a question about whether there's any data on acute kidney injury and recovered acute kidney injury rates regarding health disparities. So I'm not familiar with the latter part of your question in terms of the recovered acute kidney injury rate, but there is a body of literature that where we know that there are disparities in rates of acute kidney injury, particularly racial disparities, and there's been some literature on socioeconomic disparities as well. Um, some of it has to do some of the things that underlie that are we know that some of the clinical risk factors for acute kidney injury include having albuminuria. So we know that both Black individuals, as well as Hispanic people and people with lower incomes, have higher rates of albuminuria, even low levels of albuminuria, and that is a risk factor for acute kidney injury. So sort of reduction in acute reduction in glomerular filtration rate, and so we do know that some of those same populations have higher risk of AKI. Thanks for that. Let me go to the Dr. Kwan. Let me know if you see a question that I missed.
I think that's it. Thank you so much,
Okay.
Dr. Cruz, for taking the time to speak with us.
Yeah.
And thank you everyone for joining us. Please again return next week for our grand rounds. All
Yeah.
right.
Thank
Thank you,
you.
Dr. Cruz. Have a great rest of your day.
You as well.
Bye bye.